Yes, hello everyone, welcome. Thanks for joining us today. I'm going to go ahead and get started since it's 5:02 and we want to respect everyone's time, and we have two very special guests with us today. So I'm sure you probably don't need to be introduced, but I'm going to start with a very just quick over introduction and overview of today, as well as give you a save the date for the upcoming Aortic Dissection Awareness Week, which is happening very soon, next month, about almost exactly a week from today. So in case you're coming here and you don't know what the John Ritter Foundation is, the quickest introduction: we are a nonprofit focused on reducing death and disability from thoracic aortic aneurysm and dissection. We were founded in 2003 after after the actor John Ritter, who many of you probably know, passed away very sadly from an aortic dissection. And we do webinars like this, other patient activities. We provide free patient services, peer support, navigation, and then do some fun in-person events like the New York City Marathon. And we also fund a lot of research. So that's a very quick introduction to the foundation. Obviously, hit our website up if you would like to learn more. And this is a quick save the date for Aortic Dissection Awareness Week, and to just whet your appetite for what we have in store. ADAW, as we like to shorten it to because it's a mouthful, happens September 13th and 9th through the 19th this year. You can see we have fun things happening every day of the week. So please stay tuned. Obviously we're on the normal means social. You can sign up for a newsletter to stay tuned about what's happening, but it's going to be a packed week, and we'll have ways to participate and fun things for you to do as well as ways to advocate and make a difference. Today, we're here to talk about type B aortic dissection, and we have two wonderful guests here to explain to us more about this, as well as ongoing research in this field. Please use the Q&A to ask questions. There's a box down there at the bottom. This is being recorded and will be available for viewing later on our YouTube channel, usually within a day or two, depending on how quick on my feet I am. And you're welcome to introduce yourself in the chat and say hi to others. We also have Bella Marin here with us today, who is our patient services and advocacy coordinator. So she can help out if you have some questions about resources or how to connect in the chat as well. And thank you for being with us. So this is a quick disclaimer. You can read the full thing on our website, but essentially we're here to learn today and to be educated. What you should hear from this webinar should not be taken as medical advice, and you should not make new changes or decisions about your care based on the information you hear today. We're here to learn. So if you need help connecting with a aortic specialist or physician or other healthcare provider, please reach out to us. We're happy to help you navigate that, but that is not what we're here for today. And if you have a specific question, this is really just that information again about your own care, finding a doctor in your area, a genetic counselor, anything along those lines. We are happy to help you navigate that. So we may not be able to do it today, but please do reach out to us, and also Bella's in the chat, like I mentioned. So I will then go ahead and just do a quick introductions and then turn it over. I probably don't need to tell you all about Dr. Shalhub, but she is the division head of OHSU Vascular and Endovascular Surgery and co-directs the OHSU Heart and Vascular Service Line and the Northwest Genetic Aortopathy and Arteriopathy Program. That is a mouthful. Her clinical practice focuses on patients with genetically triggered aortic and vascular conditions such as Marfan syndrome, Loeys-Dietz syndrome, or vascular Ehlers-Danlos, as well as aortic dissection. And she's a leader and in patient-centered care and research, and someone that I admire a lot for her work on that. So very grateful to have her with us today. And then Dr. Faraz Musa is a vascular surgeon at McGovern Medical School at UT Health in Houston, Texas. And his area of clinical expertise includes open and complex endovascular repair of thoracic aortic aneurysms and type B dissections and more. And he is also a leader of an important clinical trial that we're going to hear more about today that's named Improve AD, and today we'll probably learn what that acronym means, but it's a really important clinical trial that's ongoing currently that's going to give us important information about the best ways to treat type B aortic dissection. So with that, I will go ahead and pass the screen to the two of you and let you go off, but please let me know if so there's any technical difficulties here.
Thank you. So can everybody, can you guys see the screen? Great, fantastic. So I do not, in this view, I cannot see the chat. So certainly Ellen or Bella, if you need to call an audible, please do so. Same thing with for us. It's really a pleasure to be here to give this talk. I've given some version of this talk along the years. This is the first time that I actually encouraged ChatGPT to create my slides. So hopefully you will like them. My approach also has been to try to simplify the topic as much as possible because it can be quite complex. So I don't have any financial disclosures, and I was just trying to think about questions that are from a patient-centric. If I had a dissection, what do I want to know? So these are some of the things that people in clinic usually ask. You know, what happened to my aorta? Do I need an operation or surgery? How do I stay healthy? Why do I need so many CT scans? And do I need surgeries in the future? These are just some generic questions to kind of prompt the discussion as we go through. My intent is to get through a lot of material to cover, to give you a foundational knowledge about aortic dissections. Hopefully some of it will be old news to you, at least at this point, and you've heard about it. And some of it will reaffirm what you have already learned. And maybe there'll be some new stuff that you'll learn as well. So when we talk about the aorta, my best analogy for the aorta is that it is the size of a rubber hose, if you will. It is in the chest. It runs from the heart all the way to the abdomen and carries the blood. It's a major blood supply. ChatGPT still insists on giving me 4 branches up here. We don't have 4 branches. We only have 3, but I couldn't convince it otherwise. But the point is, it's basically like a candy cane type appearance of a tube that is made out of many layers. And you can see the aortic wall layers, which are an inner layer, a middle layer, and an outer layer that have that in the aorta. And the function of the aorta is to be able to absorb the heartbeat. So it extends and contracts and extends and contracts as our heart beats throughout the body. So there's a couple of forms of pathology or diseases that can affect the aorta. One is aortic dissection and one is aortic aneurysm. And these are not mutually exclusive categories, which is why a lot of times people confuse them when they hear the terminology. So I think it's worthwhile to spend a little bit of time explaining what is a dissection and what is an aneurysm. And in short, I'm going to go back to here. This is a slide that I've shown many times, but a dissection is a tear in the wall or an artery. It could be an artery as well, not just the aorta. And then the blood flows in between the layers of the artery or the aorta. And I like these pictures here, these black and whites. And the movable picture really is showing you an intravascular ultrasound. This is a probe that we can put inside the aorta to take pictures from the inside. And what you are seeing is a circle, which is the aorta, and then a circle inside of a circle. This is the true lumen. So when a dissection happens, the blood is flowing in the wall of the aorta and basically creating this double channel configuration. So if you were to cut it across, you will see that double channel configuration. That is different than an aneurysm. So aneurysm technically is any dilation of an artery or the aorta to 1.5 times the size of normal. And an aneurysm can come in a couple of shapes, fusiform or saccular. Frequently, when you say aneurysm, people think of brain aneurysms, which tend to be these saccular or berry aneurysms. But aneurysms can affect anywhere you have an artery, and the aorta is part of that story, where it can form aneurysms as well. Aneurysms can form anywhere in the aorta, dissections can form anywhere in the aorta, and that's what they look like. Now, people can also have aneurysms and dissections in the same person and not affected. So this is a person who has, for example, this is a CT scan where they have an aortic root aneurysm, no dissection, but they have a normal size descending thoracic aorta that has a dissection. So they can also exist. Another reason why people can be confused is this picture here on the right, where somebody had an aortic dissection first, and then it became an aneurysm over time. And so in our $200 word lingo, we'll say aneurysmal degeneration due to aortic dissection. But now you can understand why, if somebody doesn't understand the anatomy, may hear the term aneurysm, may hear the term dissection and confuse the two, or don't understand what came first. So that's why clarity on what is it that you're dealing with is really important, and understanding that the two conditions are different, but they can coexist. So who is at risk for aortic dissections? The biggest offender is prolonged, uncontrolled high blood pressure, which can go hand in hand with aging as well. So that's why you see dissections occurring in people who, as they get older, and people who have had many years of uncontrolled hypertension and very high blood pressure. Also, you can see the risk factor is the presence of an aortic aneurysm or enlarged aorta. This specifically is relevant to ascending aortic aneurysm. So if somebody has an ascending aortic aneurysm, that is a risk factor for aortic dissection in that area. And that's why we fix these aneurysms before they dissect. Abdominal aortic aneurysm, which is a different location of aneurysms, tend to not be associated with dissections. And that is, again, another reason why that particular risk factor can be confusing to people. Heritable aortic disease like Marfan syndrome, Loeys-Dietz, vasculitis, and other genetic variants can predispose people to aortic dissections, but also family history in the absence of a known genetic variant can also be a risk factor. In fact, 70% of families who have aortic dissections, we know that it's familial, but we don't know what the causative gene is. And a lot of the research from the John Ritter Foundation has been focusing on trying to identify these genes. Other risk factors include bicuspid aortic valve. Pregnancy is a high-risk period for women, particularly women with genetic aortopathy or heritable aortic disease can be at risk. Stimulant drug use, cocaine and methamphetamine really spike the blood pressure pretty high, so that is a risk factor. And if they've had prior interventions in the aorta, can also be a risk factor. Males are more commonly affected by dissections than females, but both men and women can be affected by dissection. So that's also important to remember. This is an important slide in terms of how we as surgeons and physicians and people in healthcare can communicate quickly on what kind of dissection we're dealing with. And it is based on anatomy as to where did the dissection happen. So this is the latest iteration of the classification of dissections, and there have been many prior, but this is what we currently use. It's called the SVS-STS. And basically, you can see here in the peach color, if it affects the ascending aorta, then it is a type A aortic dissection. As long as it starts there, it doesn't matter where it ends. If it starts there, it is a type A. And if it starts anywhere else, it is a type B. We also classify by chronicity as is it acute or hyperacute or subacute. That means what is the interval from the time of symptoms that started? That tells you how old the dissection is. And certainly as you get past 90 days, then it is considered a chronic dissection or an older dissection. This type A and type B classification is really relevant in terms of how we make surgery decision making. If it is a type A, meaning involves the root or the ascending aorta, they need to have surgery. This is a surgical emergency. There's not a whole lot of leeway in terms of waiting. Type B dissection, on the other hand, depends on whether or not there's complications, and I will dive into that a little bit more in the subsequent slides. But the management varies between intervention and medical management only, and you'll hear more about the IMPROVE-AD trial as well related to that. So I will come back to that in a minute. Bottom line is that medical treatment is the cornerstone of all aortic dissections. Whether they need surgery or don't need surgery, medical management is what we use in all dissections, specifically blood pressure control. Every patient, every stage, regardless of treatment approach, needs medical management. So now let's talk about type B aortic dissection. When do we intervene? The big decision is whether or not there are complications at the time when somebody presents with a type B aortic dissection. So the first fork in the road, are there complications? Are there not complications? And what do we mean by that? They already had a dissection. Of course, this is a complication, but that's not what we're talking about. We're talking about something more. We are saying, does this person have a rupture? Do they have something called malperfusion? I'll explain that a little bit more in a minute. Are they having persistent recurrent pain despite optimal medical management, despite excellent blood pressure control? Do they have blood pressure that we just cannot control? Are they on 4 agents and we're just like really having them in the ICU and we're trying to give them all these blood pressure medications, but we cannot control it? Is the aorta growing pretty fast after this dissection? These are things that indicate that the aorta is not stable or it is a complicated aortic dissection that we need to treat. And the way we treat it currently is with something called TEVAR. And again, I will talk a little bit more about that in subsequent slides, or open surgery. Open surgery is the old way of doing this. We rarely, if ever now in 2026, ever have to do open surgery in the acute setting. In fact, TEVAR is still our go-to maneuver. So I mentioned the word malperfusion. It's a fancy word to say that we've cut off the blood supply to one of the branch vessels that are feeding important organs. Off the aorta, we have blood vessels that feed the intestines and the kidneys and the legs. And so if in the setting of a dissection, the blood flow to these branch vessels is occluded, that is malperfusion. And it is life-threatening and we need to do something about it. And the something about it is surgery. And we'll talk again more about how we do that. The other life-threatening complication is rupture. Not everybody with a type B aortic dissection ruptures their aorta at the time of the dissection. However, some people do. And if they do rupture their aorta, that is an emergency that needs to be treated. So then how do we treat them emergently? We treat them with TEVAR, or thoracic endovascular repair. This is basically, in a nutshell, a liner where that comes in that we can put in through the groin, through the femoral artery. We bring it up through the aorta. We unsheath it. It has a stent that looks like a liner, and it covers the inside of the aorta. And here's another picture of what that looks like. Go through the femoral artery. We use x-rays so we can see when we're going through. We use the machine to basically watch what we're doing. Here in my hand is the device. You can see the size of it. This is the deployment device, but the stent graft length can vary depending on how long we need it to be and how much do we need to cover in the aorta. And then we use x-ray to see what we're doing in order to deploy it. And so when we go back to thoracic endovascular repair, the goal is we're trying to seal that dissection entry tear. And by sealing it, we try to get the blood in that excluded lumen now to clot and do something called remodeling, or where it starts scarring and shrinking around that stent graft. So the TEVAR doesn't remove the dissection, it just rechannels the blood flow away from the false lumen into the true lumen and gets the false lumen to clot off and thrombose. I mean, thrombose is a fancy word for clot off, and to scar. This is an example of a CT scan. You can see here a big aorta that has a dissection and had ruptured. So this person came in with that rupture. The pictures in the middle are echocardiogram or ultrasound, and it shows the blood flow in the false lumen before the stent graft and how the clot is now forming after we put the stent graft. And this is the CT scan 8 months later, where you can see that this aneurysm has now shrunk around the TEVAR. So this is ideal case scenario of what we want to see when we place a TEVAR in somebody with an acute aortic dissection. This is a historical type picture of an open surgery for a ruptured aorta that has a dissection. And the picture on the bottom is helpful to see. So if you were looking at this, this is an aorta. If you imagine this was a tube, and you can see we've opened and there's 2 layers inside of that. So this is what it looks like from an open chest. The other thing about malperfusion discussion is malperfusion can present, I said, cuts off the blood flow to important branch vessels. So this is an example of somebody that their initial presentation of a dissection was malperfusion. They came in with leg pain. There was sudden onset leg pain, not chest pain, not back pain, just sudden onset leg pain. So part of the differential when we think about what is happening is to consider an aortic dissection. And this is what this person had. This is another example of somebody presenting with an aortic dissection that presented with abdominal pain, not chest pain, not back pain, but abdominal pain, because they had malperfusion. It cut off the blood flow to the branch vessels that are feeding their intestine. This is a CT scan. This is a spine. Here's the aorta. And then these are the celiac artery, SMA arteries. These are the major vessels that feed the intestines. This are the images from the ultrasound from the inside of the aorta, and you can appreciate that this is a branch vessel here and a branch vessel here, and you can see that this intima, or this dissection flap, is blocking off the blood flow into there. And so after I put a TEVAR in this particular person, it opens up the true lumen, and so now there's blood flow into the true lumen. I also want you to notice that the false lumen in the untreated area is still there here. So this is what I'm saying. The TEVAR doesn't remove the dissection. It just improves the flow into the aorta and allows that scarring that I mentioned. Sometimes we have to do additional procedures to get better blood flow in the subclavian artery. And what I mean by this is that the TEVAR, the stent graft, where we put it, generally we try to put it in a portion of the aorta that doesn't have vessels that are coming off of it. We don't want to cut off additional blood supply, but there's not infrequently we have to do that for the subclavian artery. That's the artery that feeds the blood flow to the left arm. And that's usually the dissection for the type B dissections occurs in that area. And so we have to cover that area, and we have to do additional procedures to keep the blood flow into that subclavian artery. This is one methodology. Now we have branch grafts that we can do that as well. And so the technology is improving in terms of what we can do. Sometimes we have to do something called a hybrid repair, where we need the cardiac surgeons to fix the arch, and then we can deploy a stent graft from an open chest. So that those are other sort of adjunctive maneuvers that we can do to provide that TEVAR in the aorta. Okay, so that was if you had a complicated aortic dissection. Well, what is uncomplicated aortic dissection? It seems almost like an oxymoron, really, because it is an aortic dissection, but we're calling it uncomplicated aortic dissection, and it is, so these are people who don't have rupture, don't have organ malperfusion, who are doing well. The pain is controlled with their blood pressure control, and they're recovering well. And the aorta, we scan them, at 48 hours after they've come in and been admitted to the ICU, and the aorta looks stable. So that population, we call them uncomplicated type B aortic dissection. And for a very long time, we have approached treating these people with medical management only because the risk of open surgery way outweighed the risk of medical management. And that is why we've treated people with this methodology. There's now a different way. We've talked about TIVA. I just mentioned this minimally invasive approach. So we'll talk about that. Remember that thought here. But generally, if somebody has an uncomplicated type B aortic dissection, we expect their aorta to behave in three different outcomes. Either the aorta will stay stable and not change in size over time. It may sometimes remodeling where you can see, some shrinkage in the false lumen. That's less common, but it can occur, not unheard of. And then it can enlarge over time. And this is really the conundrum. Like, how do we predict who's going to stay in the stable group versus who's going to go on to enlarge? So that today is the $1,000,000 question. And depending on who you read, we can quote people to say 50-50 chance you're going to be in the category that enlarges, or you're going to be in the category that remains stable. And so currently, when do we need to offer an operation for uncomplicated aortic dissection? Well, if the aorta gets bigger and it's growing bigger fast, or there's still a problem with blood flow, or there's new malperfusion, then we do offer an operation in that circumstance. And those who've had TVARs, they can also need other operations in the future. So just because you've had a TVAR doesn't mean it's 100% one and done. In fact, the aorta that in the other segments that doesn't have a TVAR can grow or have dissections, and they may need additional interventions or therapies or surgical interventions. And sometimes there's something called an endo leak. All it means is that there's still blood flowing in the areas that we have isolated, that the stent graft was not adequate, or the seal where we sealed the graft that was not durable, and now somebody needs additional interventions. So it doesn't mean that something went wrong per se, but the aorta can change over time. And this is why no matter what intervention somebody gets, whether it's medical management only or surgical intervention, aortic dissection is a lifelong diagnosis, and it is a chronic condition that needs lifelong follow-up. So this leads me now to the Improve AD and study that is currently happening. So remember I said, we don't know today who's going to stay in the stable group or who's going to go on to enlarge. So now people are saying, okay, since we don't know, can we just go ahead up front and give everybody a stent graft? Can we just put a TVAR and see if that makes it better in the long term? Does that prevent long-term mortality? And so that is the point of the trial. And with that, there are inclusion criteria for the trial. So I'm going to stop here, and I would ask Dr. Musa to unmute and tell people more about this trial.
Thanks, Sherene. This was incredible. I learned a lot. Just Ellen, this is the audience cannot participate, right? Only through chat. So I'm not anticipating. Okay, got it. So I'm going to share my screen. Man, I should have used Chat GPT. Replace current share. Someone else is sharing. Just stop sharing. Oh, replace current share.
I stopped. Try again.
Okay, yeah. Share. Oh, here you go. Okay. Okay, you guys see that, right?
Yes.
Yep.
Excellent. Okay, well, this was a great segue, and I think I was very clear on introduction into the disease. So this Improve AD trial, and this is the acronym here, Alan. So improving outcome, very simple to remember, and patient with aortic dissection. Now, these are the institutions below are the ones sponsoring. OHSU is one of them, and UT is another. The idea came 10 years ago. It took 10 years for this to get funded because of NIH funding is rare. The disease is rare. So convincing the government that NIH that the aortic section is important enough to merit funding to a $10 million trial is important, took some time. And finally, we were successful in getting this done. So it clearly is an important study. It's timely, it's monumental. Anytime you get NIH money is amazing. But nevertheless, when the disease is rare, the interest, obviously, industry have conflicting probably interests at times, important interest mostly, but the conflict arise when you want to stent everyone, like what Sherene was saying. What stops us from stenting everyone, and what stops us from doing medical therapy on everyone? So just a brief history onto how aortic section developed. You've seen before 2003, there was 1760, where King Charles died of aortic section. I'm talking to a crowd that, many of you have had aortic section, survived aortic section, or know someone. So this started with a type A aortic section with King George II. Nothing happened from there on, from 1760 to 1954, where the Golden Team in Houston developed the first classification, the DeBakey classification. And believe it or not, again, 20 years later, in Stanford, where Dr. Daly and Shumway described the Stanford classification. So, in what is it, 500 years, 400 years, 200 years, this is all we know. Okay. This is all we know till 1970. Now, just a trivia on how medical therapy started. So this is the section A and B, or DeBakey 1, 2, and 3. Now, how did medical therapy happen? In 1965, there is a cardiac surgeon in the University of Florida. His name is Bill Wheat, and his pharmacist. So Bill Wheat, he had an observation that turkeys were dying around Thanksgiving because of change in the grains. The grains elevated the blood pressure to a systolic of 250, and the pharmacist was giving them reserpine. Reserpine lowered the blood pressure, and the turkeys survived. So that led to, you have now more turkeys for Thanksgiving. The blood pressure lowered, and that was how medical therapy started. And the conclusion of that is we should have an alliance between veterinary medicine and surgeons, and translate that, move forward to current day, can change veterinary medicine to cardiology, cardiac surgery, vascular, a team approach of multidisciplinary team to handle this disease. So that's classification, medical therapy, and then Sherene explained how surgical therapy evolved and how TVAR happened. But in reality, speaking of the evidence that we have in 265 years, okay, so this is for the group here, which is important for all of you to be invested in this equally as myself and Dr. Shalhub and Ellen and everybody. Is 265 years. We only have 100 patients who have been randomized to stent graft, with only 70 being followed for more than a year. So that's really very little number of patients as compared to heart disease, coronary artery disease. I mean, if you pick cataract has been more studied than aortic dissection. Of course, cataract affect blindness in much more people than aortic section affect people in this country or elsewhere. But it's nevertheless, you have more than 10,000 patients, well more than 10,000 patients randomized to stent versus no stent in the heart. But we end with more than $500 million, or way more than $500 million being allocated from NIH money to study this disease as opposed to aortic dissection. So it's really important to highlight the trial. This is the trial investigators, myself with a team from Duke, and Dr. Shalhub is part of the leadership team. The main hypothesis, as Sherene indicated, is do you stent everyone up front or do you stent them when they need to? So does upfront stent graft, does it offer a superior outcome than the current standard of care of medical therapy and stent when you need it? Remember when she showed you some of them dilate into an aneurysm, and it's not actually 50-50. At best, is 70-30. Only 30% develop aortic aneurysm that needs to be repaired. So why stent 7 unnecessarily? So this is where the key question, where you create something called equipoise. Do you stent everyone up front to prevent these 3 from developing aneurysm? Or do you stent everybody up front to lower mortality, which this we don't know if it does. So that's the hypothesis that's driving this trial. It's designed in this to be in this country and Canada. 60 sites. Anybody who has no malperfusion, no rupture, as Sherene indicated, they get randomized after being stratified according to high risk features, 1-to-1. We will need 1,100 patients, and the endpoint is a clinical important endpoint, that is mortality, and also equally important major complications. So the 1,100 patients is probably being recalculated to lower because we're seeing event rate that is higher than we anticipated, which is a good thing for the trial numbers, obviously, but it's not a great thing for patients who have aortic dissection. Inclusion, exclusion, any patient who fits into the criteria of the timeline, as Sherene mentioned, acute and subacute, between 2 days and 6 weeks. If your site is a site of the trial, please ask them for it. Suitable for type 1, zone 1 TVAR, excluded. Genetic aortopathy is excluded. It's important for this crowd. And patient with what's called intramural hematoma by itself without a dissection. You're going to have a tear, as she showed you in the CT scans. The outcomes that we studied are very important. Beside death, equally important outcomes. So this is, bear in mind that everything that we will record will be important to patients. These are patients who helped us get these outcomes to be part of the endpoint. And then we're going to also collect a bunch of genetic data, imaging data. And believe it or not, we do not know the economic impact of type B aortic section ever. We don't know how much it costs. We don't know how much it costs to treat on the public sphere. We don't know the quality of life of our therapy, if it's improve the quality of life of every single patient that we do. This information is non-existent to date about the economic impact of stent graft or medications and the quality of life of patients, which we do not have. We have some genetic, but not enough. We have some images and still not enough. So this is the trial. I don't want to belabor this more, so we can open this for more discussion and Q&A, but that's the Improve AD trial.
Thank you so much. So I will share a few more slides and then we'll wrap up. And I'm hoping people can type in some questions in the boxes.
We have some really good questions that have been submitted so far. So thank you to the audience for participating. So
this will not take very long to finish. And I'm happy to share these slides. I have to say, I was really impressed with how well this program did, considering that I gave it to say, here's what I want you to say, and it drew these for me. I think this is my favorite one. So again, medical therapy is the foundation of care. So I gave it a cartoon that I liked on aortic aneurysms. I said, can you give me something similar? And here's what I wanted to say. So here it is. This is what I tell all my patients. So medical therapy, medical therapy, medical therapy. I like your blood pressure less than 120/80. I do like low dose aspirin. We talk about avoiding fluoroquinolones. This is a class of antibiotics that can be associated with tendon ruptures and then aortic aneurysm dissections. Smoking is deeply offensive to the arteries, so you got to quit smoking if you're a smoker. We want to monitor your blood pressure. If there's hypercholesterolemia, we don't want to treat that. And then daily moderate walking is important. And certainly we need to look for genetic risk factors. We cannot forget the family and the family history. And what I quote people is 20% familial. There's 20% chance that there's another family member who has this. So we need to look for that. Obviously, follow-up appointments are important and keeping, those appointments. Exercise always comes up as a discussion point, and the John Ritter Foundation has done a very nice job of addressing this. And Siddharth Prakash is a cardiologist from Houston who's well known, I'm sure, to this group, has done a ton of work in this space. But this is what I advise people, is that we don't want extreme blood pressure surges. So walking, hiking, swimming, sex, moderate exercise, housework, laundry, that kind of stuff, you can do that as long as you're able to breathe and talk while you're doing these exercises. But really, we want to avoid straining. So that's really sort of my prescription for exercise. And we know from animal models that moderate exercise is actually beneficial to the structure and the quality of the aorta. So that's another incentive why exercise is important. The CT scans or imaging in general, like why do we need so many? It doesn't matter if you had medical management only or if you had stent grafts, anything, no matter what intervention has been done to the aorta, you are not done with imaging because we have no way to see what is happening with the aorta. And generally speaking, it is asymptomatic. So we do need to keep an eye on the aorta, and this is how we can see the aorta. MRIs are also useful in some populations, and so that's an individualized decision that we make in clinic about whether or not we're going to do CTs or MRIs. But basically, we're looking for size changes, we're looking for false lumen changes, we're looking at the blood flow to the other organs, we're looking for any new dissections that could potentially happen elsewhere. If somebody's had a repair, we want to follow up that repair itself. Again, people can need potentially another procedure. So that's just something to keep in mind, that just because somebody had one surgery doesn't mean that's one and done. I can't tell you how many times people say, well, but they fixed my ascending aorta. I thought I was fixed. It's like, yes, but the rest of the aorta is still dissected. So I think it's important to remember. And then when should you call 911? I think these are the red flags. If there's acute onset chest, back, or abdominal pain, sudden weakness, numbness, fainting, and loss of consciousness, leg numbness or pain that happens suddenly, or severe shortness of breath, you need to call 911 and you need to let them know, or have your family members let them know when they come pick you up, that you have a history of an aortic dissection. Ultimately, it is possible to live in a healthy manner with a type B aortic dissection. So know your aorta. This is part of knowing your aorta today by being here. Know your blood pressure numbers. Keep your imaging and your follow-up appointments. Stay active. Live your life. You cannot stop living your life. So this is really important. And then know when to seek help and when to call 911. So with that, that's the end of my slides. And I'm looking forward to the discussion and the questions. Thank you so much.
That was great. Thank you both. I love the know your aorta talking point, and I know she wouldn't mind me sharing this anecdote, but Meredith O'Neill, who's the CEO of the foundation and a type A survivor, she'll often share that even after her dissection, before she worked at the foundation, she didn't realize that the remainder of her aorta was dissected. She thought it was fixed in surgery, and so she didn't know that she was walking around with dissection throughout her entire aorta, which was the case for her. So it's, and it's easy to not know your aorta unless you are asking those questions. So she often tells folks, like, ask your doctor to draw it for you, which I think is a really good tip. Okay, but we've had a ton of really good questions. I'm very excited, and I really appreciate the audience participation too. I think that tells you that this is a topic that needs to be talked about a little bit more. Okay, and you touched upon this a little bit there, but someone asked, do we know why some people have growth in the descending aorta after a type A and some people don't? My brother and I both had type A's. I've tried to do everything right, but mine has grown to 5.4. Meanwhile, his has stayed stable at 4.2.
Yeah, I mean, I think that's a great question on so many levels. Let's unpack it. So with the type A dissection, like we said, it's a type A because it affects the ascending aorta, but it could involve the entire aorta. So what that tells me that there's a residual dissection. I don't know based on this question whether or not your brother had a residual dissection or not, and whether you had a residual dissection or not. But let's say both of you had residual dissection, meaning dissection in the descending thoracic aorta. Just like with type B dissection, some people it will remain stable, and some people it will go on to get bigger over time. Is it a combination of genetic causes? Maybe. You now gave me an example that says, but we have the same genetics, so why is one getting bigger than other? So other risk factors are all the things I mentioned that are, hard on the aorta. High blood pressure that is difficult to control. It could be medications. Smoking is definitely a risk factor, and a variety of other things. So we don't know. I mean, the bottom line is we don't really know why some people develop and when some people don't. One of the things that I'm working on is this research study where we're doing skin biopsies, and I'm trying to look under the electron microscope on the collagen and elastic fiber structures to answer some of those questions, to say, well, can we get some insight? Because genetic testing is very useful when it shows us something, not so useful when we don't know what the cause is. So I'm sorry to say that I don't know the answer, despite the fact that and people can do everything right, but the aorta will still grow. It doesn't mean that they did something wrong. And I also want to caution people to say, well, even if you didn't do everything right, if the aorta has grown, you can't take that. I mean, yes, we want people to be responsible for their health, but I also don't want people coming in feeling guilty, like, oh, it must be something I did wrong, and that's why
Right.
it's getting bigger.
Right. Right.
Firas, do you have any thoughts on that as well? It'd be nice to hear your
No,
thoughts.
I agree. I mean, this is a family, brother, sister, so there might be something genetic, but as you said, there's way more to it. And all I gotta say to add to that is we need data, and the data comes when you collect patients prospectively in a kind of a non-biased or unconflicted way, like a trial or John Ritter does, the foundation does. So I'm encouraged in this discussion. So yeah, well, I see the questions, I guess, a bunch. So let's hope and get through them.
Yeah. Well, let's hope we can come back and answer this question in the future when we know more.
Yeah,
And this person answered
that's
that
a
with their
big
little
hope. Yeah,
sibling rivalry. I got a little tone of that in my
big
question.
hope. 4.2, 5.2. Yeah.
Yeah. Okay. My husband has a medically managed type B dissection. He is 3 years out. Oh, I think this is a really good question. What questions should we be asking at his annual appointments?
Yeah, Firas, you want to take that?
Yeah, sure. This is way up my alley. I think I'm glad that you're keeping up with the medical appointment. That is the number one thing that people tend to miss. So while before you met daily blood pressure measurements or keeping a journal is important, I do that as a hypertensive myself. And then when you go to the medical doctor, if it's the PCP, there's an annual guideline directed CT scan. So you're at 3 years, so you get a scan per year. That is for the rest of your life. If it's all stable, it's been the same for, let's say 2 years, it's been the same. So then you can space out these CT scans to every 2 years. Been stable for two studies, then you can get them every 5 years. If it's totally normal, it's been 10 years, then you can stop getting these CAT scans for a good 5 years or more. I mean, it's just a matter of how the aorta, as like Sherene was saying, remodels. If it remodels perfectly fine on medications and medical therapy, then you're not really at a very minimal risk. It depends also on the age of being normal for 10 years and all of a sudden you have an aneurysm. That doesn't normally happen that way. I mean, Sherene, anything else?
Yeah, no, I don't have anything else to add to that. I was going to pick a couple questions that I think are quick to answer as well, just so we can get through. It says, is family history a factor even if genetic testing has been done and there's no clear genetic marker? The answer is yes, because again, 70% of the time we cannot identify a known genetic variant. I factor that in the way we treat people. I do try to glean information from other family members who have the similar disease process to see if that helps understand. We do know, I have published a paper on this where we've shown that the risk of people with family history, if we lump them as family history separate from the known genetic causes, they still have more features similar to people with the other genetic causes. Not as much, they're sort of an intermediate thing, but that's because it's a mixed group of people. So that's why it's helpful to know what is running in the family in terms of features or phenotype to help guide the person who's affected. But it does matter. Family history does matter. And then there was a question about remodeling. Once dissected, and the separation healed back together, is this remodeling? Yes, that is remodeling. It's basically scar formation in that false lumen, and then it starts shrinking down. All right, those I thought were quick ones we can answer. What else, Ellen?
Okay, let's see. We did that one already. Someone says, I still have leg pain and numbness. They don't indicate what their diagnosis was, but I assume they're meaning type B dissection or type A. Will this ever go back to normal?
So it
Did
depends.
they have surgery? Yeah.
If this is, it was written anonymously, so if that was you, please, and you're still here, please answer us.
You can answer anonymously, if you will. So what I
Yes,
would
yeah.
say, the reason for the numbness depends on what caused it in the first place. Meaning, did you lose blood flow at the time of the dissection to the leg? So had that malperfusion and then needed that leg to be what we call revascularized, where we got better blood flow into the leg. Sometimes there is residual numbness with that. And so I tell people, give it 6 months to see with what you're left with. Sometimes after 6 months, if it hasn't fully come back to feeling normal, that may be the residual numbness that stays. Another reason for the numbness, if the artery was not blocked, could be injury to the nerves in that area related to the dissection. That can also happen. So similarly, if it doesn't get better by 6 months, chances are that's going to be the residual numbness there. Without knowing more, I would say that's the generalization that I can say.
Okay. Well, give me a wave if that person writes back in anonymously. Next one, I have a type B dissection, type A that's been repaired, I think is what they mean. I have 80% blockage and my false lumen is squeezing my true lumen at zone 3 to 4. This person is very on top of their details of they know their aorta well. Good job. My doctor is not interested in fixing it. Should I be worried about this?
For us?
Yeah, I can take that. So zone 3 and 4 is really in the mid-thoracic aorta. That is above the celiac artery and above the celiac artery, which is zone 5. Then normally, if there's no symptoms, I would agree with the surgeon, then would be nothing to do. It's not the lack of interest; it is just weighing risk-benefit ratio. The risk benefit is in favor of not doing, is observing. He's not doing, he or she are, it's not like they're not doing something. They're actually managing the patient expectantly and hopefully, because any procedure could lead to worsening. So just keep up a repeat CT scan and so on. I mean, this is not gonna magically squeeze everything, collapse everything, and that's how it's not the natural history. Not that we know the natural history completely well, but it's usually if no symptoms, then I would not intervene myself either. But I don't know if Sherene has a different opinion.
No, I think that's a great answer. And I'm trying to be what's the word for it? I'm trying to get through everybody's questions while we
Yeah.
can. A little bit of time.
Yeah.
Thank you. How about this one here? Or do you have one, Ellen?
I do. Yeah. Okay. Among patients who had an elective root ascending aortic repair without dissection, are they at higher risk for the rest of the aorta to have a dissection or aneurysm?
That is a lovely question. Thank you for asking that. So the point of the elective root and ascending aortic aneurysm repair is to prevent the risk of a type A aortic dissection. That's why we have guidelines around that. So the million-dollar question is now, does that alter the hemodynamics or the blood flow in the remainder of the aorta? Because now we've replaced the aorta with Dacron, which is the prosthetic material, and it's stiffer than the native tissue. So does that increase the risk of dissection? We've asked that specifically in people with Marfan syndrome because Marfan syndrome is a condition that causes aortic root dilation, and that population gets these repairs. And some literature suggests that perhaps the risk of type B dissection does increase in that population. However, One could also argue that that population has now lived longer and their aorta has been around longer and they're aging because they've had the repair to live long enough to have the type B dissection. So it's a combination of perhaps aging and changing the hemodynamic flow that can increase that risk. But that's always a hot topic still in terms of like, well, what is it that it's doing? And that's the extent of what we know now. I don't know that that has been studied in other people. Firas, do you know?
No, no, I'm not aware, to be honest.
Yeah. And I'll just note here that that question was asked by one of our new aorta advocates, and I just will take a second to plug that because there's so many patients in this chat and who joined us today. We have a team of volunteers who themselves are patients, they're caregivers, they're at risk, it's in their family, all sorts of every diagnosis you can basically think of within thoracic aneurysm and dissection. And they've come to a 3-day in-person, really intensive training where we learn how to do good listening and resource navigation, and they don't provide medical advice or anything like that. This is really talking to a peer who understands similar journey that you're on. So if you and it's all free, so and you can choose whether you do it on chat, phone, Zoom, whatever you want to do. Text. So please, if you think you could benefit from talking to someone else who knows what you're going through a little bit or has that shared experience, please reach out because we would love to have them chat with you and connect with you. And so thanks to our new volunteer who jumped in with that very good question. Okay, this may be obvious, but shouldn't subsequent surgeries for residual dissection be less traumatic than the first emergent surgery?
It depends on your definition,
Yeah.
right? Like the emergency surgery is traumatic on so many levels, psychologically at a minimum, right? And it's a big surgery, of course, requiring heart, lung machine, etc. But the second surgery depends on what the surgery is, right? I mean, we when we talk about stent grafts, and some people are candidates for these stent grafts, we'll say, well, this is minimally invasive and certainly less, hopefully, less traumatic than your type A dissection repair. But if somebody needs an arch repair, where now they have to need a redo sternotomy, going back to that old incision, and do even a more complex repair than the original operation. It's depends on your definition of trauma, but it's a bigger operation in that setting. But certainly, I would say surgeons like to do elective surgeries, and I think people do much better with elective planned surgeries where you and I agree on a calendar time to do that rather than an emergency type surgery, which is more traumatic.
But I gotta say that the it used to be 10, 15 years ago, the it's most everybody would get this big get sent to Houston, Cleveland, Boston, very select places for the open thoracoabdominal repair. And that's, for the great results and the teamwork that's involved. Nowadays, to the person who asked the question, there is an alternative to the big open whack, if you will. And these are stent graft with branches and holes in them that is available in almost every city in America and around the world, where the impact of that major initial as emergency, be it, is much less on an elective and a groin incision or groin puncture as opposed to a big incision in the chest and the abdomen. So that's been achieved with excellent comparable result, if not better than open repair in most centers. I mean, in Houston, you still argue that they do open repair just as good as ever. But definitely, even in Houston, is moving towards branched and fenestrated repair. You're
Ellen,
muted, Ellen.
Sorry, a very loud truck was driving by in my house and my window was open. So I believe that person who asked that question responded and say that they're just feeling very anxious about their upcoming type B repair. So I think the mental part is there in a different way, no matter what.
reminding people about the mental health work that you've done in the document from Gretchen. Do you want to mention that briefly?
Yeah, we have a wonderful book that was written by Gretchen McCarrick, who is a genetic counselor who's specialized in aortic disease, as well as Jennifer Rios, who's another genetic counselor in California who also works in this condition. And It's free. You can get the PDF for free on our website. You can contact us if you'd like to be mailed a hard copy of the book. And it really just goes A to Z. So, sometimes people think, oh, you're just going to tell me to go to the therapist. And there is a section on therapy and the benefits and different types, but there's also sections on journaling and sleep hygiene and meditation and peer support and, the full gamut of different interventions or tools that you can use no matter kind of where you are at in that journey. It's a little overwhelming because it's a long book, but you don't have to read it all at once. You can just take bites of it that appeal to you. Yeah, please check that out. It's again free on the website, but reach out if you'd like the hard copy or to be sent to someone who might need the hard copy. I did want to address and I get these questions all the time. I'm sure you do too, both of you, but without using their specific example, we get a lot of people asking, what supplements can I take? If I take collagen, is that going to help my aorta? 'Cause it's a collagen problem, right? Or, all these sorts of supplements, vitamins, etc. What is the data on that? And what would you recommend to your patients who come to you in general?
Yeah, so there's not good data to say that it makes a difference, but I will say what we can ascertain is a healthy diet that is not an inflammatory diet is probably better than a very inflammatory diet, right? Like I would say approaching it that way. So high quality protein, whatever that means, what I mean, like to you, whether it's plant protein or animal protein, you can debate that whichever way you want. But good protein and good vegetables, as opposed to refined, processed carbohydrates that have no nutritional value, I think that impacts your health overall. So being healthy metabolically probably would be supportive to your aorta. That would be what I tell my patients. For us.
Yeah, I mean, that's the goal, the elixir of life, right? It extends here too. I mean, good food, good sleep, stress level, all that stuff. I think we all could benefit from that. Well, there definitely patients with aortic dissection are the prime example of needing those. We all do. So again, my knowledge is as good as yours to be to the person who asked the question. And I think as Sherene indicated, good quality food. Not easy, but it's probably the right thing to do.
Mm-hmm. And we're approaching an hour here, so I wanted to end with this question because it's specifically about the study, and we didn't talk too much about that in the Q&A. But someone says, if you've had a type A repaired but continuing descending zone 3 to 10, again, great job knowing your zones, people. I'm really impressed with this. Would I be precluded from joining the study? Or perhaps a better question or way to say it is, where can we look at more information on the study?
Sure. Thank you for the question. So the information is improvead.org. So improve-ad.org. Or just look up my name or Sherene's name and it'll link us to the study. If you had a type A, so what you're describing looks like is a residual type B. So that would not be the patient population that we're studying because that residual type B may need a repair on its own or may not need ever a repair. But we are interested in those who have a de novo. If you had a type A itself by itself and that was repaired with a hemi arch or an arch, or a extended arch repair or root, and then now you have a new type B, then that would make you eligible for the trial. But the trial is Improve AD. You can type it anywhere and say aortic section will come up, and ways of participating. There's a website for it and has a ton of information on from the questions that you had. There's a good videos for patients who need a repair and why participate in this. And that's really what I would love for. I don't want to sound like it's a commercial here, but it's a direct to consumer pitch to help us get the patient. Because at the end of the day, patients really hesitate to participate. And 1 in 4 only participate in the trial because one reason or the other. So that would be patient to patient information is critical, and this forum is really important for that.
And I put the link in the chat, and then Ellen, I'm sure, will make the link available as well via John.
Yeah.
Yes, absolutely.
Thanks, Alan.
And
Thanks,
it
Sherene.
looks like there's a specific study coordinator email address too that I'm going to drop in the chat, but this will be available when the video comes out. You'll see
Yeah.
this information if you've registered for this webinar. So thank you for sharing that. And then only because, not to play favorites, but we have one other aorta advocate who's in here who asked a question. And so I want to get his out too. And he's asked if you've had an elective aneurysm repair, but you know you have one of these genetic conditions that puts you at risk, and you've had the ascending repair, could it pop up anytime that you end up with a type B dissection? Or, basically, is there a way where you can start to, let your breath out and relax a little bit? Or is it going to be, you never know when this could come?
I wish I could say you can, but we can't. And we really don't know the numbers are not very high, so I can give you some peace of mind from that perspective.
Mm-hmm.
And generally speaking, again, optimize what you can, control what you can, control your blood pressure, control your lifestyle, control the things you can control.
Mm-hmm.
Yeah.
And come back in hopefully not too long where we have more answers after things like this trial are finished. So, okay, I will end us there. We do have a few more questions, and I'm really sorry we didn't get to them all, but there were too many good questions. And I think we probably need to have you both back to answer some more next time. So thank you so much to everyone who participated and joined the chat and the Q&A. That was one of the more interactive sessions that these webinars have had, so that's great. And really both thank you to you both for taking your time to be with our community today and help us better advocate for ourselves and be more educated and hopefully participate in research, which is something that you can do. Not a lot is under your control. You can't change your age or, your genetics, but participating in research is a positive thing a step that you can take when you're eligible.
Thank you, everybody. Thanks for your evening.
Yeah. Thanks so much, everyone.
Thank you, everyone.
We'll see you soon.
Thanks, Alan. All right. Bye-bye.